Hello, and welcome to the CNS Cervical Spine Fractures video. We're going to begin by describing relevant C1 anatomy, fractures, as well as briefly discuss surgical management for these injuries. So to begin, in order to understand the pathophysiology and surgical nuances of operating on the C1, it's essential that a deep functional and anatomical understanding of the vertebra is well understood. The first cervical vertebra, also known as the atlas, is unique in both its anatomy and function. It's in the fact that it articulates with the occipital condyles. C1 lacks a vertebral body. However, it supports the cranium via the articulation of the superior articular surface of the lateral masses with the occipital condyle. This articulation also accounts for the majority of flexion and extension that occurs in the head. The inferior articulating surface of the C1 makes contact with the superior articulating surface of the axis, which is C2. The atlas can be conceptualized to be a ring where the anterior arch and posterior arch make up the front and back of the ring. The anterior arch is of relevance as it articulates with the dens. The distance between the anterior arch and the dens is often measured to assess the integrity of the transverse ligament, as this ligament holds the dens adjacent to C1 and prevents C1 to subluxation. Lastly, the transverse processes of the atlas house the bilateral vertebral arteries that course cranially and posteriorly through the V3 segment. The posterior course of the vertebral artery along the sulcus arteriosus must be well understood, as posterior arch dissection and lateral mass group placement places the operator adjacent to this vital artery. Atlas fractures account for 7% of the cervical spine fractures that I encountered and have a bimodal presentation pattern. The injuries seen usually in early adulthood following MVCs or high energy axial loads lead to atlas fractures. The second distribution of prevalence occurs in the elderly, where osteoporosis and comorbidities lead to fractures of the atlas after lower energy trauma such as ground level falls. Lastly, given the relatively capacious nature of the canal at this level, patients with isolated fractures of the atlas will often present with neck pain only and no neurologic dysfunction. There are various classifications of atlas fractures. A frequently cited method is the Guilherme classification, which contains 5 types of fractures that are characterized based on the anatomical location. Further subclassifications are also incorporated to account for the integrity of the transverse ligament. Type 1 fracture is a fracture of the anterior arch. Isolated fractures like this occur following a flexion and loading injury and is considered a stable fracture managed with a cervical collar. Type 2 fractures of the posterior arch. Isolated posterior arch fractures can fall after a hyperextension injury and is associated with a low energy mechanism such as ground level falls. It's also common to see coinciding odontoid fractures with this type of fracture. Similar to type 1, these fractures can be managed with a cervical collar. Type 3 fractures are also known as Jefferson fractures, involve the anterior and posterior arch. This fracture pattern is seen after high energy axial loading injuries, and stability of this fracture is determined by integrity of the transverse ligament. Because of the importance of the transverse ligament in surgical decision making for type 3 fractures, further subclassifications have been developed to categorize these fractures. Type 1 is defined by an intact transverse ligament and can be managed with a collar. Type 3B is defined by a compromised transverse ligament. A Dickman type 1 has direct injury to the transverse ligament and is considered unstable. These isolated fractures should be surgically treated with C1-2 fusion. Lastly, a type 3B with an intact transverse ligament but with bony avulsion, otherwise known as a Dickman type 2, is also considered an unstable fracture. However, surgical management with a halo vest can be considered reverse surgical management in the appropriate patient population. The Guilherme type 4 and 5 fractures are fracture of the lateral mass and transverse process respectively. These fracture patterns occur following an axial loading and rotation injury. These fractures in isolation are considered a stable injury that can be managed with a cervical collar. The status of the transverse ligament can be quickly assessed radiographically. 2 common ways of assessing are via an open-mouth odontoid view X-ray to measure the lateral mass displacement. Transverse ligament disruption in setting of a type 3 fracture allows for lateral mass migration of the C1 lateral masses. If the sum of the lateral mass displacement is greater than 6.9 millimeters, also known as rule of Spence, there is a high suspicion of transverse ligament injury. Additionally, the dental interval calculated on CT or lateral X-ray can also help determine the status of the transverse ligament, as injury to the ligament allows for C1-2 subluxation and enlargement of the space between the arch and dents. Greater than 3 millimeters in adult or 5 millimeters in children is highly suspicious for transverse ligament injury. Lastly, an MRI of the cervical spine without contrast can also directly evaluate the integrity of the transverse ligament. When surgical fixation of the C1 vertebra is required, lateral mass screw placement requires an intimate understanding of the relationship of the lateral mass with the vertebral arteries, articulating facets, and underlying neurostructures. Screw placement often requires meticulous dissection in order to visualize underlying and surrounding anatomy. Screw placement begins with identification of the screw entry point, often considered the intersection of the posterior arch and the C1 lateral mass. Screw placement should be performed under fluoroscopy or with the use of navigation. Screw trajectory is often directed 10 to 15 degrees medially, and in the craniocaudal trajectory is performed with the use of fluoroscopy to direct the screw to the midpoint or directly below the midpoint of the anterior arch. Next, we'll discuss C2 and relevant anatomy, pathology, and surgical management of fractures. C2 anatomy is comprised of an odontoid process, also known as the dens, pedicles, covered above by the superior articulating process, the inferior articulating surfaces, the lamina, and the vertebral foramina bilaterally, the transverse processes, and the spinous process. C2 fractures are very common in the terminal population and account for between 9 to 18% of the fractures seen in the cervical spine. They come in two major categories. The first category are odontoid process fractures, which themselves are divided into three subtypes, which we're going to discuss next. These make up approximately 2/3 of all C2 fractures. The second category of C2 fractures are those of the pars interarticularis. Classically, if bilateral pars are fractured, we call those a hangman's fracture, and we'll discuss a little bit more in the following slides. So when it comes to odontoid fractures, they're usually caused by hyperextension, hyperflexion injuries. There's a bimodal age distribution in the young and the elderly. Type 1 fractures are usually when the rostral tip of the odontoid process is avulsed due to the apical ligament pulling forces. Type 2 fractures often occur between the transverse ligament and the body of C2. Type 2 fractures has the highest rate of non-union, ranging from 25 to 86% non-union in the literature. This is due to the fracture involving considerably less trabecular bone and being under distractive forces from the apical ligament. Type 3 fractures involve extension to the vertebral body and or lateral masses of C2. Depending on the level of displacement, they may be stable or unstable. Hangman's fractures, also known as bilateral C2 pars interarticularis fractures, are not the fracture most associated with hanging, despite the name, but instead are commonly from hyperextension injuries such as motor vehicle crashes or diving accidents. There are subtypes here as well with different grading scales. The important point to keep in mind is that the lower types are based off minimal displacement without neurologic symptoms. These are usually managed conservatively with hard arthrodesis and follow-up imaging. The non-displaced types or patients with neurologic symptoms often require posterior decompression and fusion. Treatment of odontoid fractures varies in complexity, primarily based on patient population and the degree of fracture and displacement. In type 1 fracture, most patients do well with a period of immobilization in a hard cervical collar. Interval film should be obtained prior to release from collar. In both type 2 and 3, the patient's demographics, meaning body habitus, smoking status, age, medical comorbidities, must factor in on the decision-making process. For poor surgical candidates with minimal displaced type 2 or 3 fractures, external orthosis can be considered either via cervical collar or more commonly halo vest immobilization for several weeks and repeat films prior to removal. Posterior atlantoaxial arthrodesis, C1 lateral mass screws, C2 pedicle screws or par screws, C1-2 transarticular screws are all viable options. Odontoid screws are a good option for younger patients with a minimally displayed odontoid. It preserves motion, therefore it's an osteosynthesis procedure. It avoids arthrodesis. Older patients are less likely to adequately fuse. If the fracture mass compresses the cord, this is not a good solution. Risk factors include initial displacement more than 5 millimeters, inability to maintain alignment non-surgically, ruptured transverse ligament, non-reducible fractures, and non-union for more than 3 months. Posterior instrumentation with or without transorodontoidectomy is the maximal surgery that these fractures require, which ensures internalized fixation for stability. If the odontoid is compressing neuroelements, the odontoidectomy becomes important, especially in a non-reducible state, which will require instrumentation to then restore stability in these patients. Next, we'll discuss subaxial cervical anatomy, pathology, and surgical management of these fractures. And to begin, it's important to understand that there's two major classifications for subaxial cervical injuries, and those are the AO spine classification and the SLICS. We'll briefly discuss both of these. The AO spine subaxial classification system basically comprises its injuries into three major categories: compression, tension band, and translation injury. And then there are two other major categories, including facet injuries and bilateral injuries. No bony injury or minor injury, such as an isolated lamina fracture or spinous process fracture, occurs in this classification, and unilateral facet injury can be classified as minor and therefore managed conservatively if the fragment elastic is 1 centimeter and is less than 40% of the lateral mass. The Spine Trauma Study Group Subaxial Cervical Spine Injury Classification, SLIC, basically categorizes fractures depending on morphology, integrity of the disco-ligamentous complex, neurologic status, which are incorporated into the score. The score then becomes 1 to 3 should be managed non-surgically, 4 is a surgeon's choice, and 5 or more warrants surgical management. It's important to keep in mind that ultimately the loading force determines the fracture pattern observed. Independent of the classification used, it helps to think of subaxial fracture types in terms of the loading force applied at the time of injury. The loading force determines the fracture pattern observed, which along with the neurologic examination can help with determine management. Subaxial fractures can occur with varying forces applied with the spine in a flex, neutral, and extended position. There are minor fractures that can occur in each one of these injury patterns. Minor fractures of the cervical spine occur usually in flexion, neutral, or extension, and unilateral minor facet injuries are classified as F1 in the AO spine schema. If neurologically intact and no retropulsion of bone, typically treated with rigid orthosis for 8 weeks. Flexion extension films prior to discontinuation of orthosis is usually necessary. Next, we're going to discuss in the flexion mechanism injury, the axial compression fractures. Axial compression fractures usually involve a single end plate in the cervical subaxial spine. If neurologically intact and no retroportion of bone, they typically are treated with rigid orthosis for 8 weeks. Flexion extension films are usually obtained prior to discontinuation of orthosis. Next, we're going to discuss teardrop fractures in the flexion pattern of injury. Teardrop fractures in severe forms can lead to significant ligamentous disruption, and they're usually associated with neurologic injury. They require specific discussion here as they're a result of a hyperflexion injury with axial loading. These forces result in compression of the anterior column with tension on the discoligamentous complex. Imaging may reveal a small chip of bone beyond the anterior inferior edge. They can occur concurrently with other fractures through the vertebral body. The involved vertebral body may demonstrate retrolisthesis and prevertebral swelling. If the injury is primarily posterior due to discoligamentous disruption, posterior fusion is sufficient. Severe forms with canal compromise can usually require an anterior and posterior approach. Next, we're going to move on to the extension pattern of injury and discuss avulsion fracture. Avulsion fractures are an extension injury type of fracture, and they have a similar appearance to a teardrop fracture. However, this is a hyperextension injury due to traction on the anterior longitudinal ligament. These fractures usually do not cause instability, therefore distinguishing between a teardrop and an avulsion fracture is of clinical importance. The following criteria can be used to differentiate them from a teardrop fracture. The patient needs to be neurologically intact, the bone fragment is small, there is preserved alignment, there is no additional vertebral body fracture, especially in the posterior elements, there's no prevertebral soft tissue swelling, and no loss of vertebral body or disc height. If all criteria are met, it's possible to obtain flexion extension x-rays, and if normal, rigid orthosis with follow-up can be recommended. Next, we'll discuss quadrangular fractures and the flexion pattern of injury. A quadrangular fracture is a vertebral body fracture with posterior subluxation of the vertebral body. There is usually angular kyphosis and disruption of the disc and anterior posterior ligaments. The treatment is usually surgical and may require combined anterior and posterior fusion. We will now discuss subluxation injuries with and without locked facets. So to begin with, locked facets. So locked facets are flexion injuries that can result in displacement of the facets. Flexion and rotation leads to unilateral locked facets. Hyperflexion can lead to bilateral locked facets. Closed reduction may be performed if there's no large traumatic disc. Traction manipulation can be employed for these. You can obtain an MRI for traumatic disc herniation, and if present, closed reduction is usually contraindicated. The usual weight is 10 pounds per vertebral level for reduction, and if closed reduction cannot be achieved, the patient will need open reduction and fixation. Here we can see an example of closed reduction using traction manipulation. Once reduction is achieved, the need for operative intervention can be assessed. Posterior approach is preferred if there's no anterior disc, subluxation is greater than 1/3 of vertebral body, or for fractures of posterior elements. In the extension injury pattern, we'll now discuss lateral mass and facet fractures. Lateral mass and facet fractures result of extension combined with compression. There's various classification schema. Catani et al. Described 4 patterns of lateral mass fractures, which include separation fracture, comminuted fracture, split fractures, and then traumatic spondylolysis. The separation fracture is a fracture through the lamina and ipsilateral pedicle. It creates a floating lateral mass, may be associated with anterior longitudinal ligament disruption and intervertebral disc injury, and it's usually an unstable fracture. A lateral mass and facet fracture in a comminuted classification involves multiple fractures through the lateral mass and facet, and is associated with lateral angulation deformity. Split fractures are a coronal fracture in the lateral mass. Traumatic spondylolysis is the result of extension combined with compression that results in bilateral horizontal fractures through the pars interarticularis, and there is usually a separation of the anterior and posterior elements. Most of these fractures can be treated with a posterior approach, one level above and below the fracture. The posterior approach uses usually fixation with screws, lateral mass or pedicle screws, and rods extending up and down. Simultaneous neurodecompression is performed when needed. Additional treatment with an anterior approach may be required for release of rigid deformity or for additional anterior column support. Some separation fractures may be candidates for osteosynthesis to preserve motion using a cervical pedicle screw that transverses the fracture. An anterior approach is an alternative. Advantages of the anterior approach is that only one level needs to be fused. The disadvantages is the decompression of compressing fragments cannot always be accomplished and requires disrupting an area that may not be compromised. If there is subluxation, the anterior column is probably compromised, however. Next, we will discuss the axial compression fractures in the neutral mechanism. The axial compression fracture in neutral category usually results from axial loading of the spine in a neutral to a slightly flexed position, which eliminates the cervical lordosis and therefore causes the injury pattern. They're associated with neurologic injury due to the rupture propulsion of the bone fragment, and surgical intervention usually requires anterior versus posterior or a 360-degree fusion. Of note, C7 axial compression fractures carry a higher risk of developing a kyphotic deformity than other levels due to the cervical thoracic junction. The cervical approach for these fractures, most can be managed with posterior approaches with instrumentation above and below level of the fracture. Anterior approaches are useful but may not allow for adequate decompression. Neurodecompression must also be performed when necessary. In patients with a spinal cord injury, assessment of neurological status in presence of spinal shock is important. If a patient has a complete spinal cord injury, operating does not result in significant restoration of function. The primary goal of surgery is stabilization and allowing for rehabilitation. If the patient has an incomplete lesion, surgical decompression and stabilization should be performed as early as possible. Central cord syndrome may constitute an exception to this rule, although there is variability in schools of thought regarding management of this pathology. When it comes to anterior versus posterior approach, the choice of technique depends on the mechanism of injury as previously described. The aim of the surgery is to correct instability and perform decompression when necessary. Some injuries may require combined anterior and posterior approaches. An example of that is an axial compression fracture and a teardrop fracture. A posterior-only approach is usually a procedure of choice for most flexion injuries. Exception may be a teardrop or severe flexion destruction injury, useful when minimal injury to the anterior columns. Posterior ligamentous complex disruption, subluxation, locked facet, or simple compression fracture. When anterior column is compromised, combined anterior-posterior approaches may be needed. Just briefly to describe the posterior technique, various techniques exist for placement of lateral mass screws. Typically, entry point is established 1 to 2 millimeters medial to the midpoint of lateral mass. There is a medial lateral angulation that varies from 0 to 30 degrees depending on the technique, and craniocaudally angulation varies from 0 to 15 degrees depending on the technique. It's also important to discuss closed and open reduction if, for example, you're talking about locked facets. Decompression must be performed when indicated, and extension of the construct to T1 or T2 if the cervical thoracic junction is involved is usually important to avoid adjacent level breakdown. When it comes to anterior approaches, these are not dependent on integrity of the posterior elements. The indications are extension injuries, fractured vertebral body with retropulsion, usually with axial compression fractures, severe posterior element fractures that preclude posterior instrumentation, and subluxation injuries. For the anterior technique, an ACDF suffices when compressive lesion is a ruptured disc. A corpectomy is used when compressive lesion is fractures and retropulsed bone. In this case, the compression may require a wide corpectomy to avoid vertebral injury. Do not exceed 3 millimeters lateral to the medial edge of the longus colli muscle. A graft fusion is usually performed with either bone. You can do a strut graft with homologous or cadaveric bone, or a synthetic cage, titanium or PEEK, depending on preference. Complication of surgical management, hardware failure, In brief, these include anterior cage and plate failure, screw injury to the nerve root, spinal cord injury, or vertebral artery injury, inadequate postoperative mobilization, non-union, and lastly, judgment error leading to the improper approach.